having problem how to start AMSP. So that's why we have got registration from Rajasthan to Assam, from Puducherry to Himachal Pradesh. So many people are online also. So, and everyone have a different perspective of antibiotic stewardship. Like out here, so out here to a prescriber, he thinks that stewardship practice is a good antibiotic at a proper duration for proper time, not giving it in a viral infection. For a pharmacologist, it is giving it in dose adjustment and as per requirement. For a microbiologist, it is as per the bug that we are and as per the antibiogram we are making. In the process, we forget that there are other people are also in the wings, like the pharmacists, like the infection control people, and like the other IT and healthcare support personnel also. So AMSP is actually should be a wholesome process, and if we think of AMSP, it is almost like the idea of alchemy, as in the book Alchemist. At the beginning, we have a belief that it's something like some superhero will come and give the right antibiotic and will kill the bacteria and patient will be relieved from any infection. But practically, when we go deep inside, it's actually a philosophy. It's actually something much more than changing a copper into a gold. So how to start with it? It have to be structured, and we have gone through various guidelines like IDSA and CDC as well as WHO guideline. And those toolkit has been shared in the WhatsApp group, and we will be sharing with all the delegates whose email ID are already there with us. So we'll start with what IDSA says, how to go about. This is for the naive people who want to start AMSP in their own hospital, and for those individual delegates, we already have our masters who will be teaching us how to do all those individual things. So first and foremost thing is that we need a antimicrobial stewardship team that should contain one infectious disease physician, one clinical pharmacist, one clinical microbiologist, one infection control professional, one hospital epidemiologist. Now this is the wholesome process that should be there as per IDSA, but we know we live in a resource poor country. So when we go deep into their description, then they say it can be diluted to as many as in a PhD. If only a physician and a pharmacist is there, then a AMSP team can be formed by those two also. So it will be as per requirement of that hospital. This is the ideal, because we know in India we have less number of ID physicians, and microbiologists are also clustered in big hospitals and in a teaching institute only. So IT also plays an important role, but everything have to be integrated along with the other committees that a hospital have to have anyway, like hospital infection control committee, the therapeutic committee, and all the other committee. So if this antimicrobial stewardship team is integrated with all those, then only a wholesome idea and wholesome philosophy of a good stewardship practice can be started. So what are the elements that are given in IDSA? It says that microbiology plays an important role, like making the antibiogram for the infection as per pathways. Then we should have a antimicrobial order form, and all those guidance are given with gradation of A, B, C. A means that there is a good evidence that they will help AMSP practice. B means there is moderate evidence. C means there is poor evidence. And it says that microbiology laboratory, clinical guidelines, prospective audit, de-escalation, a proper method of de-escalation, policy for conversion from oral to parenteral therapy, those are having a good evidence that those are good AMSP practice. Now this antimicrobial order form, it is having moderate evidence, but when we will learn in next sessions that how to do it, we will learn that this, if we have a antimicrobial order form, then doing all those prospective audit and feedback and audit would be easier for us. So this is important. Then formulary restriction is there for the country, but there are various formulations which are prevailing in the market. So hospital administration should have a good look in all those formulary that are there in the hospital. Combination therapy, it has its own positive and negative thing. Definitely in empirical therapy it has some role, but once diagnosis is made by microbiology, then its role goes down and down. That is why it is having matlab very less evidence that it will help, but definitely it is helpful in initial. And research, we often forget that research is also part of AMSP. Research does good work in AMSP, and research has a bad thing too that we need all acknowledge in our private conversation. Many people sit over their data and they do not release it for the patient benefit. So for proper AMSP practice, it is the need of the hour that research publication, we release it with the individual who are using it, so that we can improve on patient care. So CDC and other toolkit also are saying how to frame a antibiotic stewardship program for your hospital in a similar way, but their questions are little bit tactful, like okay, do you have a antibiotic stewardship committee, but are they having enough time to manage all those activities? Is your IT team is supporting your MSP practice? Because right now, entering for microbiology, we can speak that we are doing the antibiogram for the hospital, and we are processing around 200 samples a day, so around 60 to 70 bacteria a day. So putting everything into the data at the end of 6 months is a herculean task. If IT team can just extrapolate the data to us, all the time would have been could have been given to some other work. So these are the future things that we can do in coming time. Besides that, this stewardship team can always serve as a link between all the community, and they should not be a people with halo around them and they are not approachable. Next slide, please. And just to keep a balance on the thing that things are happening regularly, CDC toolkit says that are you regularly meeting, committing meeting for your stewardship practice? Next slide. Then the leadership commitment that they are defining is that besides that stewardship team, the other people who caregiver, other support team, are they having enough time? Because it is our nurses, it is our IT team, it is our MRD department, they are also our pharmacy, they are also a big part of our AMSP team. So can they devote enough time for AMSP practice? Then there are various quality indicators we will learn in next master session. So are they integrated into the hospital's system of quality indicator? Thanks to NABL, NABH or this Kayakalp, we are now maintaining the data of needle stick injury, CLAPSI, or the other thing as quality, bed source as quality indicator. But are the things that are done in stewardship practice monitoring, they are a part of hospital process indicator. So besides that, nowadays we have our own India's own surveillance system for MDRO and hospital acquired infections. So
Actually, any hospital should join into it so that they are at par and know what is there and what is the difference of other hospital. And once a AMSP team is formed, then they should be held accountable for what they are doing. Next slide, please. So besides that, the pharmacy people who are actually delivering, dispensing the antibiotic, they should also have enough experience on stewardship so that they can help us effectively. And besides that, there have to be intervention time to time. So these are like recommendation based on local susceptibilities that microbiology usually do come up with antibiograms of the hospital. For community acquired hospital, community acquired infection, we already know the organism and we already have 2 national guidelines which are in practice, and there is not much difference, not much change in their registogram. Next please. Then if this thing like sepsis and staph aureus infection and culture proven infection have been there in the hospital, then are specific action plan to tackle them? Then is prospective audit and feedback is taking place in your hospital? As we could see in the IDSA guideline also, it was numbered as A1 in AMSP practice, matlab a must for any AMSP practice. So this prospective audit, we will have a separate session for it in coming time. We will learn it from the masters. Next slide please. And pre-authorization of some antibiotic is having its own ifs and buts. We will discuss in coming time. Next slide. So besides that, there should be a policy for prescriber to document the entry of dose. That antibiotic order form that was in B as per IDSA is also recommended in the CDC toolkit, that we should have it in our hospital for proper monitoring. And a formal daily review of the antibiotic that are being used in the hospital. Next slide please. Next. So by doing this, we will come to know what are the opportunities to improve, like tracking the antibiotic use and submit, monitor prospective audit and feedback, monitor pre-authorization intervention by tracking, monitoring adherence. These all could be a part of our quality control practice in AMSP practice. But as Dr. Dilip Natwani says, that if we can make all of them our target, that from tomorrow we will do all this, then definitely by end of 6 months we will lose all our energy. As he said, that we should be resilient enough so that survive and tackle each problem individually. We should do one baby step at a time as per all the guidelines that are available. This is a wholesome guideline of an extremely good antimicrobial stewardship practice. Next. So these are the part of prescription form, like antibiotic timeouts, then the OPAT policies for discharged patient, then track antibiotic resistance. This has improved over the years because all the microbiology lab who are involved and who are concerned nowadays doing it and releasing their registogram to the hospital staff. We are also doing it. And next. So this is same as what IDSA has said, that as per antibiograms, susceptibility will be different in different hospital, and we should adhere to it by proper prospective audit and feedback. Next. So besides that, one more toolkit is there, that is WHO Practical Toolkit. This is basically meant for the nation. Out here, we all know about the Jaipur Declaration and the Chennai Declaration and the red line over the antibiotic. And many times we laugh with each other because till today we can go to a pharmacy and buy colistin or vancomycin just like that. So that is why we should go to the next step which is marked in the last point, that are we monitoring our progress, what we are doing and what we should do at the next level. Next slide, please. So for that, there have to be some rules and regulations, and there are some rules and regulations that can be there made in the hospital itself. In a central institute like ours, where all the antibiotics are given to patients by the central pharmacy, so we can have some check and balance over here. And we were talking about pre-authorization. So for pre-authorization and all, who has already categorized the antibiotic into aware group like XX, WATS and reserve. So for the reserve drug, we can have developed a policy of how to do it in coming times. Next. Then if we do how to do it, then eventually we will know for our hospital which would be the practical way to deal with this problem of super bugs. Next slide, please. So measuring the antibiotic consumption and other thing, that will be dealt in the separate session in coming time. We will be learning in coming 2 days. Next slide, please. Then one thing that everyone says is education, and everyone frowns upon when it comes to practicality. Because by just wearing a blue cloth in a week or making some rangoli is not enough intervention. And we know how this WhatsApp University and Google Doc is controlling our patient. Most of the time it is patient which is insisting on antibiotic. So for as an example of whose guideline of educating all the people about awareness antibiotic, Canada started a campaign that do really bug really need a drug. And it was taught not even to the adult but even in the schools. Just like nowadays we are teaching students in the school about pollution. So that kind of impact might have been there. If we can start something like that in community level, then only after 5-6 years people would be aware that this azithromycin will not help you treating your corona. But CDC's advice on education is much higher level, and what they say is, next slide please, what they say is about a handshake stewardship. What is this handshake stewardship? We have been talking about this prospective audit in IDSA guideline as well as in CDC guideline. So out here, once you do prospective audit and do not pre-authorize in all the antibiotic, but daily go into round and have a discussion, then this has a very good effect, and that is known as handshake stewardship, which is a education at a higher level for the all. And as Dr. Dilip Natwani is also saying that this education is not only for the school child or for the young doctors, it is for the adult and the experienced prescribers as well as experienced microbiologists as well as experienced pharmacologists also, because things are changing like anything every day. Next slide please. So this surveillance thing has been recommended by IDSA as well as EA, and it is responsibility of any microbiology lab who is doing culture sensitivity do compile survey, then report it to the higher authority. In India it's ICMR, so that we can do a proper, we know where we are living in. So besides that diagnostic test, this microbiological small culture sensitivity is not present in peripheral hospital, district hospital. Those are actually concerns of today, need to be addressed by higher authority. Next. So from the outside, AMSP, antibiotic steward, looks like a superhuman who will save us from superbug. But actually, when we go to the essence of antibiotic stewardship, it is not a superhero, but it is a wholesome idea of empowering everybody and making everybody aware and making everybody a superhero so that they can fight the bug together. Next slide, please. So, and that will not finish the story. We have to propagate our knowledge to the community. Now, this thing cannot be done. When we talk at our individual level, we say that हमारे यहाँ तो नहीं हो सकता है क्योंकि ये problem है. But look back in last 6 years. Hospital Infection Control Committee 6 years back was almost a redundant thing. But now, today, most of the medical colleges in India are having a vibrant hospital infection control committee, and which is helping the antibiotic stewardship. And 6 years back, we were talking about, yes, we have miles to go in hospital infection control also, but we have a structured idea of hospital infection. So that we can take as a silver lining. Besides that, anyone's patient who is admitted in ICU, then only we know what is a superbug and what can it do. Otherwise, we think that, oh, they are treatable by colistin or vancomycin. So this is AMSP. The idea of AMSP is empowering everyone with knowledge and doing it in day-to-day practice. Thank you. So what we are doing in AIMS Patna, that we would like to share. This is the introduction to AMSP. For what we are doing in AMS Patna, we are doing only baby steps, and for it I will like to invite Dr. Asim sir for us, who is one of the 4 pillars of microbiological democracy. Asim, please come. Thank you everyone for your patient hearing.